verbiage, both at the Medicare policy and also in your LCDs, depending on your region, because those are the words and the catchphrases that, as best you can, educate your referral sources and the other healthcare providers that you work with at PT groups and home health agencies to be able to use those words, such as motivated to ambulate. Because if the patient is not motivated to ambulate and we cannot prove that they are going to reach or maintain a functional state within a reasonable period of time, then we're going to find that that lower limb prosthesis is not going to be paid for, and if it is paid for, you're going to have it recouped. So when we're looking at building a prosthesis on paper, obviously we're building or constructing it with L codes to paint the picture to Medicare as to the prosthesis that we have dispensed to the beneficiary. The medical necessity for certain of these components or add-ons that we're using is going to be based on the patient's potential functional ability, both current and potential, and it is based on reasonable expectations of the prosthetist, the treating physician, as well as other people related to the rehab of that patient, like a physical therapist. Patient's history is going to be really important on a new amputee as well as an existing amputee. The existing amputee, this recent history may be a little easier to use to justify the kind of prosthesis to dispense because obviously there will be a track record of what that patient can and cannot do with a prosthesis. But that track record will only be there if you're educating the patient